So our third speaker, I told you we had two attorneys, and we'll have another on our panel. I was going to say we have our token physician, but actually we have two physicians because David Sherrill will be speaking on the panel as well. But Brent Williams is a physician here at the University of Michigan. He's also has a master's in public health from Harvard. And here he is responsible for the populations that we're talking about today, the uninsured, the low-income populations, both for the educational, for the teaching mission of the university, and also for much of the clinical practice. He's been involved in the county health plan in Washtenaw County, and is so really familiar with the kinds of issues we've been talking about on the ground. And we're delighted to have Brent here to join us. And I don't think it's coming up on the screen, but so you'll have to look behind you. Sorry about that.
Okay.
Peter broke the sheet.
Thank you, Marianne. It's a pleasure to be here. I was pleased to get an invitation to come and think out loud with you about some of the things that are going on at the ground level, especially in a forum like this where we have to start thinking together about the next world, which is uncertain at best, but promising for sure. So among my hats, one central one is medical director of the Complex Care Management Program here. We'll talk more a little bit about what we do, but I want to be sure you know for the, I was going to say cocktail hour. For the reception, Donna Fox is a nurse administrative manager of the Complex Care Management Program. Think about her as you choose who you want to interact with. Wealth of knowledge. I saw Diana Arnold, who's a care manager at the Delanis Shelter for homeless persons. She's a clinical care manager. And Robert Kraft was here and may come back, he's coming back. So these are folks who work at the homeless shelter, for which I have the privilege to be the medical director of our clinic there as well. Seek them out. They are fonts of wisdom. As a little bit of context here, we in the Ann Arbor, Ypsilanti area are in a kind of FQHC-free zone. So, yeah, and it's important to put our experience in the context of FQHCs throughout the country, but it may help illuminate areas we're not alone, where FQHCs don't have a dominant front and center presence. We do have a strong presence for public mental health here, though. We've been very benefited by a strong leadership in the public mental health system. Our local version is called Community Support and Treatment Services, CSTS. And we've partnered with them fairly heavily, and they have a lot of involvement in the community. We also have a county insurance program, Washtenaw Health Plan, which has been an important partner, as well as the county itself. So these are our local resources that have been a pleasure for me to partner with. I need your help up front. I'm going to ask everyone to raise their hand at least once, if not 4 times, to know who you are. How many folks here are bringers of new knowledge to the world? This is researchers who spend a substantial portion of their time doing research and trying to illuminate reality amongst us. Bringers of new knowledge. Great. Or, yeah, repeating. How many have spent a significant amount of your time in administrative services? That is, administering organizations. Great. And how many have spent their time in direct care? First, for non-health professionals. I want to hear folks who have day-to-day clinical contact with folks, but not in a health professions context. And then how many health professionals? Great. So it's a pretty good mix. Actually, the researchers are the least represented here in our University of Michigan. So that's helpful to me to know kind of how to pitch my thoughts. Okay. I'd like you to, by the time I finish, I'd like you to know a little more about a particular group of people. They're high utilizing, low income, underinsured. The nexus of those 3 areas, which is where I spend a lot of my time. It's not all the and underinsured. It's certainly not all low income, because a large part of my efforts have been devoted towards the high utilizing. We'll talk about non-high utilizing folks as well. But within that group, I'd like you to have an understanding of their clinical conditions common amongst them. I want to give the non-health professionals a clinical sense of who they are, and also a sense of how they interact with the health system. And finally, thinking forward, I'd like you to have some ideas about what features of the new world have to be present to best meet the needs of this group of patients. This group, it's obviously not homogeneous. It's not them out there, they is us. But folks that have these characteristics. What should the new world look like now that we have some opportunity to paint a new picture? I'll say only a little bit about the challenges and opportunities for health professions, education, and care of vulnerable populations. I decided there just wasn't time to do both. So I have one slide at the end on that. We can reserve the rest for questions if we get to it. So let me first introduce you to some folks. LM, 64 years old. She has end-stage renal disease. She's on dialysis. She comes to the university 3 times a week for dialysis. Over the past 12 months, she's admitted 13 times for a variety of things: hypotension, dehydration, electrolyte abnormalities, C. diff colitis, an iatrogenic form of severe diarrheal illness, failure to thrive, a complex construct with physical dysfunction, social, psychological dysfunction, as well as medical deterioration, and others. A real polyglot range of clinical problems. She has multiple medical problems, multiple somatic complaints, and limited adherence. She oftentimes doesn't come for appointments. When care managers or nurses go to her home, she's often unaware of her medications, unable to describe how her medications are managed, but lives with her son, who has a developmental disability, not well characterized in the chart as far as I could understand. Described as limited in coping skills, limited insight, felt to have medical decision-making capacity on some deliberate attempt to manage that, or to assess that. Now, as I'm going to describe 3 other patients before we move on to some of the implications. I'd like you to put yourself in the position of a healthcare provider, a physician in primary care, a care manager making a home visit to this individual, a nurse in a clinic or in a homeless shelter who's trying to deliver service, a nurse practitioner. Our clinic at the homeless shelter is staffed primarily by nurse practitioners. An outreach worker whose job it is to get in a car every day and go to tent cities and encounter individuals and try to find ways to get them engaged in healthcare. So provider, take the provider's point of view for a minute as we think about these. You may be this person's primary care provider who works at Brighton. He's a general internist. His visits are scheduled every 15 minutes. And on an average day, on an average half day, he sees from 11 to 16 people, one of whom is this woman. What resources does he need? What resources does he have to try to help participate in the care of this person? Second patient, 35-year-old female, type 1 diabetes, chronic kidney disease, not quite on dialysis, but heading that way, bipolar disorder. She's been hospitalized 11 times with 13 emergency visits in the past year for gastroparesis, abdominal pain, and I would add in here narcotic-seeking behavior. Notice the high ratio of ER visits to hospital stays, right? So that's an indication that whenever she comes into the ER, it's very, very difficult for the ER staff to find a safe way to return her home. She gets admitted. Her income is Social Security. She's on medical disability. She has very limited social support, basically one sister who has a very love-hate relationship with her and is frankly fairly burned out. The patient herself is frequently uncooperative, demanding, non-adherent, leaves the hospital against medical advice frequently. Now, I'm her PCP. So I can tell you she's stormed out of my office on more than one occasion, madder than you can imagine at me, with lots of downstream implications of that behavior as well. Now, my visits are scheduled 30 minutes apart because I'm an academic and I have a little bit of flex in my schedule in my practice. But by and large, she's been cared for in our residence clinic. And so when she comes now, and just recently I took over kind of primary, because it really wasn't working with the residents being her primary caretakers. But so I'm typically the last few weeks, we've seen her every 2 weeks for the last 6 or 8 weeks. And in my residence clinic, I'm staffing. I've got backed up lines of residents waiting to staff. And I walk in the room, and I'm 45 minutes before I walk out. That's even with her legal guardian and or her public mental health care manager in the office with me and her. Next patient, there's only 4 of these, but I wanted to give you a kind of a smattering. Now, this person is not a high utilizer, but I put him in here because he illustrates some folks that maybe ought to be high utilizers, right? They're out of the system for inappropriate reasons. So he's 45. He had a motor vehicle accident in 1985, suffered a crush injury to his left foot, is in chronic pain, and he now has recurrent DVTs and pulmonary emboli, life-threatening condition, treated with chronic anticoagulation, Coumadin. Coumadin requires that you come in regularly for your blood checks, and you have a phone, and you can respond to our recommendations for adjusting your medication. He's homeless, hard enough to find him on a good day, but he's a binge drinker. I love this guy. You talk to him, he's friendly, articulate, always sober, well-dressed when he comes to his appointments, but he recurrently drops out of contact. I've sat with him, I said, Mr. S, you have a cell phone? We gave him a cell phone, right? At one point, got him the cell minutes, the special minutes that you can get. I said, promise me you're going to hold this with you. Do you have a charger? Do you have electricity? He said, yeah, I got all that, got all that. No problem, doc. I can't tell you the number of times. Then on that Friday afternoon, I get a call from our anticoagulation clinic. He came in to get his blood drawn, but his anticoagulation is flamingly out of control, like serious risk of bleeding. Can't get him, right? Phone doesn't work. So that's happened to me maybe a dozen times over the last year. However, he's not been hospitalized, and he has rare outpatient visits because he oftentimes doesn't come. Not because there's not somebody trying to go find him and bring him in. So what am I supposed to do with him, right? So here the question with him has to do with what do we do with the Coumadin? He's got a life-threatening condition indicating Coumadin therapy. Much less how do we care for him in a broader sense. All right, the last patient for your thoughts. This is a 52-year-old male with alcohol dependence, polysubstance abuse, including cocaine and heroin, alcohol-induced psychotic disorder with hallucinations, who is homeless. And over the past year, he's had 12 university emergency visits, no admissions, 1 St. Joseph hospital admission, all of them related to alcohol withdrawal. He basically pops out of the system, goes back to the streets, binge drinks, gets into physical trouble from intoxicated behavior, gets brought into an emergency room where he basically dries out. At any one moment, I'm told there's 5 to 6 folks in our ER and 5 to 6 folks in the St. Joe's ER who are simply there to dry out. And then they go back to the streets for the most part. He also has had 14 jail sentences. All right. Where do we want to go? I want to think clinically about these folks. Now, we at the Complex Care Management Center have come to a way of understanding the enormous heterogeneity of patients who are, we've called them complex. We use the word complex in a specific definition, which is if you take the 7 domains that we have listed up here, major psychiatric disorders, behavioral disorders, substance abuse disorders, multiple and severe medical conditions, limited social support, limited resources like housing, transportation, electricity, food. and limited functional capacity. Those are actually 7 separate axes. You can be impaired in any one, but not necessarily the others. And by and large, the uniform characteristic of our patients, of our complex patients, is that they have a major impairment, major hit in at least 2, more often 3 of those domains. A little bit about the domains. Let me just ask, Marianne, what time is my ending point? Great, thank you. So the major domains, major psychiatric disorder puts us cheek by jowl with the public mental health system. In many ways, it works quite well. In many ways, it's quite dysfunctional even to this day in our system. There are still huge firewalls, in part driven by the public mental health code and partly driven by culture. Behavioral disorders. Behavioral disorders are a really pretty common theme. I really think they underlie the vast majority of patients that we find most challenging. What do I mean by behavioral disorder? I mean personality disorders. I mean the tendency for an individual to split, to not show up for appointments, to, by deliberation, appear in different parts of the system. Substance abuse disorders. We, in the United States, as a function of our great dedication to treating unmanaged pain, have brought upon ourselves a separate, very difficult, very epidemic proportion problem, which relates to narcotic seeking among patients with labels around chronic pain. Big subject, don't need to go into that, but it's huge and it's hugely important. Substance abuse services, as well as narcotic-seeking behavior around emergency room arrivals, are an important and dominant theme. Multiple and severe medical conditions, limited social support, housing. Let me go down to functional capacity. So functional capacity is almost any cause. In our older, frailer patients, that has primarily from cognitive impairment. But medical frailty leads to physical inability to manage daily lives, as well as just functional mechanisms. That is the ability to manage information, responsibly plan your day. Lots and lots. When we did a pilot study here looking at patients who were discharged from our hospital to homelessness with ongoing medical needs and nowhere to go to have those medical needs, whether it's wound care. One of the themes that surprised me was that a tremendous number of those folks, a percentage of those folks, actually have not only medical needs, like wound care change needs, but functional needs. They're not able to do basic activities of daily living, like eating, bathing, dressing, grooming. They're so debilitated. Now, where do you go to find services for that, for at least a temporary period? So functional capacity is its own independent measure. So 3 patterns I'd like to point out that are kind of uniform a large number of these patients. First, multiple sourcing of care. Now, I keep going back and forth between this issue of multiple sources of care, fragmentation of care, and ACOs. All right, so what is an accountable care organization that we'd like to create? What opportunities are there to address this huge fragmentation of care, both across the public mental health and medical health worlds, and then across systems, hospital systems, and then in the inpatient to outpatient arenas, all of those domains. There's an enormous problem with fragmentation that potentially there's an opportunity under the ACO model. Second, patient behavior can drive the system. It means it matters the incentives that patients see for healthcare-related behavior matter. What kind of incentives should that be? What kind of structure should there be? What kind of options should patients have or maybe not have in terms of an environment in which they can receive optimal, coordinated care? There are frequent interactions with public mental health, substance abuse treatment service, and social services. You have to be able to solve that problem, right? You have to be able to have effective communication lines between the medical care system, the traditional healthcare system, and public mental health, substance abuse treatment service, social services. Here, FQHCs, of course, are a model because many of those features are baked in. Certainly substance abuse services, social services, mental health services, all of those are baked in by mandate. to the structure of an FQHC, but not baked into the structure of most of the healthcare system. The healthcare utilization is high. These are just some figures that I found striking. These are not new. Anywhere you go, you can find this, 5% of the patients consume 50% of the healthcare dollars kind of ratio. No exception here. Look at the top 45 blue K, that's the Medicaid HMO. For the 12-month period, 09 to 10, had a median of $70,000 of expenditures with a range as high as $200,000 and a total expenditure of $3.7 million. These are some older figures. I needed some, at least back of the envelope figures to talk about average costs rather than only talking about outliers. About the 05-06, these are just the most recent figures that I had easily available to me. The Medicaid HMO, at that time, the average individual was about $8,000. So these range from $8,000 to $11,000. Notice, per person, notice that dual eligibles are popped up as a very high utilizing group, including those dual eligibles under 65. They actually capped the list. This is a national figure which it says the same thing about dual eligibles on a national basis. Compared to other Medicare beneficiaries, dual eligibles both under and over 65 are an extremely costly, high utilizing group, high need. I mean, think about it. What does it take to be a dual eligible, right? You have to be under 65. You have to be very poor, and you have to have some qualifying condition for Medicaid services, usually a fairly profound form of disability. To get Medicare under 65, other than end-stage renal disease, it's by and large fairly profound mental or physical disability. So it's a very high-need group. I want to throw one last patient at you to let you know. This is, again, I begin thinking about not only dwelling on outliers. Here's a non-outlier. He's a 30-year-old. We typically encounter folks like this, 30-year-old male with mild chronic low back pain. He's been unemployed for 6 months. He fears eviction, discord with his girlfriend on evaluation. He's depressed and anxious, but not suicidal. So he has moderate depression, not many resources. We see these folks in our residence clinic fairly commonly. He's eligible for county insurance, but enrollment is currently closed. And his access to mental health services under any existing scenario is extremely limited. What would you do with him? How would you advise him? What's that? Yeah, there's a familiar ring. So, thinking about the mean now for a minute rather than just the outliers, the gaps in services that are most prevalent from my point of view have to do with mental health services for moderately ill folks. The severely and persistently mentally ill, by definition, have some access to mental health services, limited though it is. It's not perfect, but there is some through the public mental health service. But for moderately mentally ill patients, there's nothing who have limited insurance. It's a real clinical issue on a daily basis. Medications, lots of help came through with the $4 plans through the big box stores. No question that's made a difference on the ground. But still, medication access remains an important daily struggle. And then interestingly, at least in our area, dental services. They just keep coming up. Everywhere you go, it's dentistry. The world would pay somewhere. Somebody is willing to pay for the dental services that are part and parcel of. Okay, I'm only a little bit worried. I have no idea. Yeah, that's why it's 5 in the morning. It's incredibly well timed. So as we think now I just want to challenge in the last 5 minutes, I want to challenge our thoughts towards the next world. Now what happens as we experience a tornado or power outage? As we look towards the world under the PCMH, the Patient-Centered Medical Home, and the Accountable Care Organization, wherever the politics may head us, there is an opportunity to think openly about this. So what are the strengths and limitations of primary care practice in its current form from caring for complex patients? What evidence best guides our health system designed to care for complex patients? In primary care for complex patients, the dominant features include time-limited visits, limited assessment capabilities, right? Assessing patients like the ones we've talked about here is a complex, high-order skill. It requires knowledge and skills in behavioral assessment, psychiatric assessment, substance abuse assessment, as well as lots and lots of medical assessment and social service assessment. It's difficult to find somebody who does all those well. It takes a team. Also, limited intervention capacities, right? There's care direction, coordination, resource, referral management, and behavioral management planning. Now I have 4 minutes left. So I want to talk about care management for a minute because I've learned a lot about it in our complex care management program, and I want to talk about its key features so that we can hold a discussion about how that might fit into the new world. We know from lots of demonstration projects in vulnerable populations, and I've listed some of them here, and under the literature calls some of these geriatric comprehensive care, assertive community treatment through the mental health paradigm, healthcare for the homeless programs, and then chronic care management, which is the name that Massachusetts uses for its dual eligibles. Those are all programs that have demonstrated productive models in caring for complex patients. The common elements include effective selective patient enrollment, comprehensive and accurate clinical assessment, that's comprehensive, multidimensional clinical assessment, clear delineation of responsibilities and team membership. That's a care team. So you have to define the care team. You have to know who they are. They have to know who they are. And they may not be from the same institution. Effective care management, care planning and implementation, which requires real-time communication across systems in many cases. Recognition, mutual recognition of team members. So there may be a care manager at St. Joseph Mercy Hospital who needs to be in communication with the care manager at the Delanus Shelter. Completely different institutional organizations on completely different information systems. Timely access to needed information, skills and experience with behavioral management and substance abuse, and then outcome measurement with meaningful feedback loops to key stakeholders. Those, in my view, are the essential elements of a successful complex care program. At the center of it is in every model that I'm familiar with, care management. That is the presence of a care manager who both helps guide and coordinate care. So this is the complex care management program. We sit as an independent organizational unit within the University of Michigan, whose job it is to try to tie as many places together as possible in the care of individual patients. So we connect heavily to the hospital and emergency room by getting daily discharge reports from every patient discharged under our care, largely low-income, uninsured or minimally insured patients, including Medicaid. And we work with the PCPs and their office staff and their nursing staff to try to collaborate with the PCPs to create a care management plan. Now, what's going to happen to this structure under an ACO? I don't know. That's what I'm here to learn from you. This is our basic model. The patient's at the center. We have a care manager. There's a primary care provider. That means physician. We're unabashedly saying there's a physician there. And then other members of the team. In our context, it's the practice itself, which includes usually a key leader, nurse, clerks, and then the presence of protocols for communication at the level of the site. Last question. I have 60 seconds left. Perfect. This question is, what are the implications now in caring for currently un- and underinsured patients for health system design under global funding and expanded insurance? My conclusions for today, to start the conversation, first, most low-income un- and underinsured patients will have expanded insurance, although I'm not clear what their mental health services will be, and have problems that could be managed in a well-functioning patient-centered medical home. These are, for the most part, they will not be folks who will skip across systems and have difficult management, behavioral problems, but for the most part, they could be managed well within a well-functioning patient-centered medical home. What's that going to look like under the new payment structure? We've learned a lot about the opportunities in FQHCs for that. However, for a significant minority of very expensive patients, key challenges will not necessarily be addressed in any of the formulations that I've seen around the ACO or PCMH. How well will these new formulations address